Good morning, everyone, and welcome to all participants who have taken time to join our live webinar today titled COVID-19 Towards Endemic Phase. We apologize for a few minutes delay due to some technical glitch at our end. I think now we are good to go. My name is Dr. Ajit Pal, and I work at Pharmaniaga as Head of Biologicals. And I would like to extend advanced greetings on upcoming Raya celebrations next week to all our participants and speakers. We are already 2 years into current pandemic, and some of the countries who have vaccinated most of their population are planning to phase out from pandemic to endemic stage of the disease. However, WHO and some of the world experts are a bit skeptical about this decision and are saying that it could be too premature, mainly because since most of the world population is still unvaccinated and we are still seeing new variants and subvariants of COVID virus in the population. Malaysia started its successful vaccination program early in 2021, and by now we have almost 90% adults, elderly and adults vaccinated here in Malaysia. However, pediatric vaccination less than 11 years of age, we still have very low coverage, which is close to 45% until last week. This low coverage is a great cause of concern, especially because of new Omicron variant, which has a very high transmissibility. And we also know that this new variant is being transferred as an airborne route as well. We are also seeing a high in severity and number of cases in pediatric population from Omicron across the world, which was not there with earlier variants of COVID virus. In today's seminar, we will be addressing some of these concerns and discussing how we are moving forward from pandemic to endemic phase. And we'll also present new data on effectiveness of COVID vaccine from Sinovac, mainly with respect to pediatric population and for new Omicron variant in Chile and Hong Kong. Our first speaker today is all the way from Mexico, Dr. Alejandro Cravioto. Dr. Alejandro is here at Scientific Advisory Group of Experts at WHO. SAGE is a nodal body of experts which advises WHO on various interventions, strategies, recommendations for vaccines, and including for COVID this time for the last 2 years. Dr. Alejandro is a pediatrician by training and has been a chief executive position at various international organizations in the past. Today, he will talk about COVID-19 pandemic from the global perspective and what do we expect moving forward. Our next speaker is Dr. Gao. Dr. Gao is a medical director at Sinovac and has 20 years of experience in epidemiology and immunology. Before joining Sinovac, Dr. Gao has been working with China CDC and multinational organizations in China like Pfizer and Sanofi. His talk will focus more on the COVID vaccine effectiveness data, and he will also present the new study on the booster dose in pediatric population. Our final speaker today will be Dr. C. Hui Cheng, who is head of pediatrics and neonatology at Sungai Buloh Hospital, Selangor. Dr. C has been at the epicenter of COVID-19 management, especially in pediatric population. And we will hear from him on the COVID-19 effect and management in pediatric population here, and also his view on the vaccination and the recommendations in Malaysia. Each speaker will speak about for 20 to 25 minutes, and followed by every talk, we will have a Q&A session. Participants can drop in their questions in the chat box, and we will take these questions after each talk. We have some housekeeping rules for the webinar today. All participants will be muted during the presentation. For all questions, as I said, you can drop your question in the chat box and we will address these questions after every talk. And at the end of the session, we will project a QR code which will be which you will receive 1 CBD point for all medical practitioners in Malaysia. So without wasting much time, I will hand over to Dr. Alejandro from Mexico. He is currently based there with a time difference of 14 hours. Dr. Alejandro, the floor is to you. You can project your slides.
Thank you very much, Ajit. I thought that you were going to project my slides.
We can also do that. We can also do that. Let us project.
I think that may be easier so that they are properly done. And first of all, thank you very much for the invitation to be with you this morning for you, this evening for me. I am very pleased that we have the time to talk about these important things. And I hope that my talk gives you a perspective of how we're seeing things in that sense. So if you could give me the first slide, if that is possible. There we are. The next one, please. What I will talk are three different parts of this presentation. We really want to know where we are and what we have learned so far over the past 2 years. So first, I will talk about the COVID-19 pandemic and a vaccine update. Then I will talk about the unintended impacts of the pandemic, and then finally on the opportunities for immunization and beyond. The next one. As we can see, over the past 2 years, we have had a massive amount of infection worldwide, which is now coming slowly to a decrease. The issue here, as you can see from the graphs on the right side, is that each region into which the WHO is separated has really a different type of epidemic curve. While in some areas, like in the European region, the cases are really going down. In the Western Pacific region of the WHO, the cases are going up still in a way that is worrying in the sense of what might happen and if they're going to go down as in other places as before. The next one. As we can see also, we have had over the past 2 years a number of very important milestones. It is amazing that despite the amount of problems caused by the pandemic, we have been able to do two things. One is to develop and use almost immediately a number of vaccines that have helped us to control the pandemic. The second is that there has been a quick development of drugs that have helped also to control the rate of infection and the severity of the infection. And the third one, which I think is just as important, is that we have found a mechanism of financing for these vaccines that goes beyond to what was usually done through the Global Alliance, which was mainly to support countries with low income to have the basic pediatric and adolescent vaccines that were necessary to control vaccine preventable diseases. Here we have a whole new perspective of how we can find a common fund that will allow us to spend money to produce and to use the vaccines, especially to send them out to countries that have no financial capacity to use them otherwise. The next one. In that sense, the next slide, please. What we can see in this graph is the way these new COVID vaccines, no, the one before, please. The slide before, that one. As you can see with this graph, the way things have been developed and tested take between sometimes 10, 20, 30 years. And in the case of the COVID vaccines, in less than a year, we have had the development and the production of vaccines. What was amazing in this case was that the money to be able to construct the necessary facilities to produce the vaccines was done and invested at the same time that the vaccines were being tested in different trials around the world to test whether they were efficacious and safe to be used in humans. This learning experience has allowed us to understand that confronted with an emergency such as a pandemic, we have the capacity to do things that we don't normally do with the development of these products for normal use, and also a learning experience of how we can speed up the process to use new vaccines in development in a much faster way to how we have been doing it in the past years. The next one. Now, if you look at the way that the countries have been having access to this vaccine, it is obvious that the wealthier ones, because they are either the producers of have the purchasing capacity, have been able to go much faster in the vaccination rate of their populations than the countries that have a more constrained economic situation in which the vaccines have been getting to them in a much slower way. The other problem we have had is how do we actually go and vaccinate groups of people that we were normally not touching with our vaccination programs. In most low and middle income countries, vaccination stopped in adolescents and pregnant women, but we didn't go beyond that. And here we have had to vaccinate older groups that were normally not the subject of our programs. And that has taken a real planning and implementing a system that has needed to be developed in each country and that has had different successes in that sense. Still, the idea that most countries need to achieve at least a 70% vaccination rate of their populations to be able to curb the pandemic and to move, as Dr. Pal was saying, from a pandemic to an endemic situation is still the goal that we need. And for that, of course, each country needs to take into account its own epidemiologic situation and its own demographic situation. It is not the same thing to have half of your population above 50 years of age than to have half of your population below 15 years of age. And in that sense, there will be a talk about pediatric vaccination as the third talk in the webinar that I think will give us a much better perspective of what that means. The next one. Now, as you can see, of course, by income, the countries that have had more access to the vaccine have been the ones that have for now been able to vaccinate most of their population. On the other hand, it's also important to say that these high income countries have had the highest number of people who have been reluctant to get vaccinated. If you look at figures in the United States, for example, you can see that despite all the efforts done and all the availability of vaccines in each pharmacy around the country, only 65% of the whole population of the United States has been fully immunized against COVID. So it is not an issue of availability of a vaccine, but of the acceptance to get vaccinated. And of course, adults who don't accept to be vaccinated will certainly not vaccinate their children. So you continue to have these pockets of unvaccinated people, which at the end of the talk, we will see the importance that they have for this concept of herd immunity. The next one. The next slide, please. Now, in WHO, from the beginning, the Strategic Advisory Group of Experts defined a roadmap that, no, the one before, please. A roadmap that was constructed based on a number of ethical principles to be able to cover initially those populations that were at higher risk of severe disease or of death as the vaccines became available. And what we saw from the beginning was that anybody above 60 years of age and the whole health force had a priority as groups to be vaccinated because that was where the most of the deaths and severe disease had been concentrated. This use of this system, which was modeled before and then shown in practice to be the way to curb the amount of people going into a hospital and the amount of people dying, has proven to be very effective. With the idea now of vaccinating 70% of the population as a goal, Then we have moved to a second roadmap, which includes also not just the primary immunization, but also the booster doses. And we continue to insist that the first people that need an extra dose of the vaccine, since, as we will see before, the circulation of different viruses as the virus mutates and moves along creates a problem both in the amount of immune system security to be able to curb the virus, and on the other hand, the waning process of the same immune response that most of the vaccines that we have used so far have shown. In difference to vaccines that we have used in the past that have shown very little waning over time, these new COVID vaccines have shown that in 6 to 9 months after the primary immunization process, most of them have a lower level of antibody response that doesn't cover specifically some of the more virulent variants that are circulating as part of the evolution of the virus. The next one. So in that sense, we have been able to control the pandemic despite the capacity of the virus to mutate and to adapt in a different situation to the forces that are going against him, mainly with the amount of people that are now immunized or infected from the virus. And in that sense, as you have been probably very much aware, we have had the designation of new variants that have sprung out and spread efficiently with this Greek alphabet system that now classifies them into one of these groups. We started with Alpha, which was a variant that started mainly in Europe, and then we went through all the other processes, and the last one is this Omicron, which started in South Africa and has spread around the world. In the sense of the other variants, especially before Omicron, the most worrying one was Delta, which started in India and which had the capacity not only to spread more easily, but also to cause a more severe disease that was worrying in the sense of the impact it had on our health systems. For now, Omicron, as Dr. Pal was correctly saying, has had a capacity to spread more, but to cause a much less severe disease, although it infects more children than the other ones for two reasons. One, because that's the unimmunized population that we have throughout the world. Those are the people, the children who have not been vaccinated because we haven't had vaccines for those age groups. And on the other hand, for the capacity of the virus to cause a milder disease, even if it has the capacity to infect more people. These two things have given a different type of immune response to the previous variants. And so far, what it has caused has been a massive amount of new infections, many of them in people that had already been fully immunized or vaccinated. The next one. Now, one of the things that has been a worry is whether the vaccines that we have been using are capable of neutralizing these new variants, especially when they are so changed by these mutations that they have, that they don't even resemble very much the original virus. As I make a joke about this, if the Wuhan virus was the great-grandfather, he would look at the Omicron great-grandson and say, well, he does look like me, but I don't think he's part of the family. And in that sense, I think that these constant mutations of the virus have also made it different to how we have seen in the previous waves of different mutants as they move along. So far, with the capacity of the vaccines to give a primary immunization and then the enhancement of the immune response through a booster has been a good response to be able to control even the spread of Omicron or the capacity of Omicron to infect but not to give a severe disease. The next one. The industry, the producers, of course, have looked into the possibility of making new vaccines based on these new variants. And of course, the vaccines produced through an mRNA platform are the ones that have the fastest capacity to be able to change the antigen from the original virus to a new mutated virus as part of this vaccine process. These vaccines are only started to be produced. As you can see, they're still being published as a preprint that will go through the whole process of peer review before it's published officially in one of the journals. But it is a way of showing that we can adapt the vaccines that we have to the new variants to be able to control them. The same thing can be said in the next one to the way we use the vaccines. And one of the things that has been proposed in the next one is the idea of mixing and matching the vaccines that we have. We published, a group of us, a paper in Lancet some weeks ago in which we went through the evidence that we had about the benefits of combining the use of these vaccines in the next one, and we came out with a number of conclusions that have also been adopted by SAGE. In that sense, as you can see here, by combining vaccines, you can get an increase in the immune response that you have already obtained from the initial immunization, and that is then a capacity not just of the booster, but of a much better booster if you're using a combination of vaccines. In the next one. On the other hand, we continue to recommend as a standard practice the use of homologous schedules. That means we use the same vaccine in the same way that we have published before, both for the primary and for the boosters. In that sense, the Strategic Advisory Group of Experts and WHO has supported a flexible approach to vaccination and recommends at least 2 homologous or heterologous doses of a vaccine that has received emergency use listing as a way of constituting a primary series. This is different for the inactivated vaccines, in which we have said that primary series should be at least 3 doses, especially if you're talking about people that have problems or are immunocompromised. Now, countries using inactivated vaccines may consider using mRNA or vector vaccines as a booster, and countries that have been using vector vaccines should also consider the use of heterologous boosters with mRNA vaccines. In the case of the mRNA vaccine so far, except for the use of a vector vaccine as a booster, most of the data that we have, especially coming from places like Israel, shows that it is better to give a 3rd or a 4th dose of the same mRNA vaccine. What we do insist is that there should be no delay in favor of any of these schedules, be it homologous or heterologous. The use of the vaccine has to be as fast as possible and as efficient as possible. The next one. Now, the second part is what has happened with the pandemic. And here, the next one, we have 3 basic problems. One is, the next one, an increase in the number of children that haven't had a single vaccine. The next slide, please. What we call 0-dose children are children in any country that haven't received a single vaccine throughout the beginning of their life. And in that sense, we have a large number of children that have been left without their common vaccines over the past 2 years. And at least most of the countries have had to postpone or to delay vaccination campaigns for many of the things. The next one. This has caused a problem that is mainly related to diseases that we have seen in the past are capable of giving large outbreaks. One of them, of course, is measles. Why are we worried specifically about measles? Because we have also seen 2 things, an increase in the levels of poverty and an increase in the levels of malnutrition. And the combination of these 3 factors for any child in the world are a death sentence. And let's not put it mildly. Malnourished children who become sick with the measles die in a high proportion, and we just saw that in a large outbreak in Madagascar 2 or 3 years ago. So in that sense, the idea that we need to speed up our vaccination campaigns that have been delayed, and countries need just to look not just at COVID, but also at the other things that are needed to make sure that the population is safe, especially the children, needs to be something that is called an urgency and an emergency and needs to be addressed as soon as possible. The next one. Finally, as the third part of the talk, what are the opportunities we see in the part of immunization and beyond? The next one. One thing that is clear is that given the way that the pandemic has gone, and given the number of cases and the number of variants that have been happening over these 2 years, the idea that we had initially that we could, by vaccinating 70 or 80% of the population, reach a level of herd immunity is something that doesn't seem to be feasible nowadays. The next one. In a recent paper, you can see that in difference to the influenza epidemic 100 years ago in 1918, in which there were 50 million deaths and 500 million cases, in this case, because of the vaccines that we have had the same number more or less of cases, close to 500,000, but we have seen only 6 million deaths. That means that we have had a way of curbing this problem in a much more efficient way. However, as with influenza, the next one, we can see that the concept of reaching the whole population to be able to have this coverage of 70% is very heterogeneous depending on each one of the countries, because the highest risk populations are not the same, especially from a demographic point of view, in the different countries in the world. It is not the same thing to be in Zambia or to be in Malaysia than to be in Mexico, the United States, or France, or whatever. Each one of the countries has a different situation that has to be addressed to be able to see which are the groups that need to be vaccinated and how far down in age do we need to go to be able to cover the 70% of the population. The next one. Now, the threshold of herd immunity is, of course, the proportion of the population that needs to have immunity against a communicable disease, either by vaccination or by infection, in above which the transmission of the agent is largely prevented. In the case of measles, we know that those levels are above 85, 90%. In that sense, once we reach those, we have seen a drop in the number of cases. And of course, our famous and only one preventable disease that we have been able to curb completely has been smallpox, in which we were able to achieve herd immunity at the world level and then be able to eradicate the disease from the face of the earth. The next one. So in that sense, there's a recent paper published by Tony Fauci and others in the United States. The next one, please. In which they have clearly noted that this concept of classical herd immunity that we have seen with measles and polio is not easy to attain because we have a virus that is behaving in a different way. And even if we have these vaccines, we haven't been able really to control the spread of the virus, and the virus keeps changing in these new variants that are giving new types of infection, even in people that have already been infected or that have been vaccinated. What is encouraging is that in the past 2 years, more vaccines, and especially the boosting of the vaccination, have achieved a level of population immunity that allows us, together with the drugs and the monoclonals that have been developed to be able to treat patients who get infected, to be able then to start looking into a way in which we can go back to some kind of normality in our society, in the sense of not allowing the virus to have community spread. That means our children go back to schools, we go back to our works presentially, we go back to our normal type of life, but we need to keep on addressing a number of issues, both from the point of vaccines and from the point of other interventions, which are mainly this non-pharmacological intervention, such as social distancing, the washing of hands, and the wearing of masks. The next one. In that sense, what we are looking into now is this idea of hybrid immunity. Here, the evidence that we have so far is that the combination of infection plus vaccination can give us a much better perspective of protection than simply one of them along with the other. We do not recommend, of course, that people get infected if they can avoid it. The idea that you can have consequences from having been infected in what's been called this long COVID is not something that cannot be taken into account. So any type of prevention of infection is still a goal, and that is what we want people to get vaccinated and boosted as much. But in the case of the chances of waning immunity because of the vaccines, and the idea that the virus can mutate and then cause these infections, as we have seen with Omicron, then of course the combination of these two ways of defense become part of something that we can see as a future way of controlling the problem. The next one. And in that sense, here you can see this graph at the end, especially by October of this year, of last year, in 2021, October of 2021, you can see that a high proportion of the people around the world have already been exposed to the virus. And this exposure to the virus, in the next one, either through infection, as you can see from the left, or through vaccination, as you can see in the right, gives the two things the quality of protection in the sense of being able to have either a milder disease if you get infected, or actually preventing from having a new infection. In the Western Pacific, in the high-income countries in Europe, or in the high-income countries of the Americas, this immunity has been achieved mainly through immunization, while in Southeast Asia, in Africa, the infection process has been so high in a much younger population that has made a huge difference to how the infections have fared in other parts of the world. And even if the vaccination has been much lower, you have now, in a sense, a similar level of protection between the two systems. The next one. Now, are we sure that this is helping? Well, in an analysis done by WHO, you can see that from 20 epidemiologic studies, given 49 estimates comparing hybrid infection to induce immunity, 80% of those studies consistently show that this hybrid immunity was better than infection-induced immunity. That means the idea that the vaccines are being helpful even in people who have been infected is essential. 10 estimates show no difference between them, and there are no studies that find that hybrid immunity is any worse than either vaccination or natural immunity. In that sense, then, if we can increase the level of vaccination in the next months, if we can maintain the level of infection rate as we have seen, and especially this drop after Omicron, and if the virus offers us the chance of not having a new mutation coming up because there's no population left, as was in South Africa, in Europe at the beginning, or in India for the Delta variant, then we might not see one of these new variants coming up in the recent weeks or months. And in that sense, we might be in a much better position to control what is now really circulating, which is the end of the Omicron phase. Excuse me. The next one. This week, we are celebrating So in that sense, we're looking forward then to something that will allow us to develop a different way of looking at it. Finally, there's this idea that we might be looking at a new way of dealing with the virus by making different vaccines, and one of them of course, is a vaccine that would be able to prevent all types of coronaviruses. Remember, we have had SARS, we have had MERS, now we have had COVID. So in that sense, there are groups, especially in Europe and the United States, already working on this, making a single vaccine that would help us in that sense. Is it possible? We've been working for an influenza one for many years and we still don't have it. So we will see if it happens with this approach. In the meantime, we will require both the vaccination and the non-pharmacologic public health interventions to be able to maintain as much of a normality on our lives as possible, and especially for our children to go back to school, which is something that would really affect the future of our populations if we were not able to do. The next one. This is the final slide. This week, starting on the 24th, we are celebrating World Immunization Week, and the theme is long life for all, and especially safety and effectiveness of vaccines, the concept of equity in which everybody needs to have access to these products, and of course, diseases prevented, which is the main thing. The lead line is vaccines in pursuit of a long life well lived, and the hashtag are long life for all and World Immunization Week and vaccines work. So please share it with others in the sense of having at least a celebration and a look at the future, which is a bit more optimistic than we have had in the past months. Finally, my last slide. Thank you very much. This is a view of my university in Mexico, from which I am happy to have been able to be with you this evening. Thank you very much, Ajit.
I think now the floor is open for the questions and we wait for the questions. But in the meantime, it seems that the world is now divided between the two. On the one side of spectrum, we have countries like China, which is fully vaccinated with very less infection in the population so far. On the other side, we have a countries like Africa, which are very less vaccinated and a high infection rate. Now, in between is Malaysia. Malaysia is around 90% vaccinated for adults, elderly. My question to you is, what is the recommendation for someone like Malaysia, where we are kind of 70 plus vaccinated, 70% plus coverage, but our neighbors are still 50%, like Bangladesh, close to 50%, Vietnam also very less, and new variants coming in our region. India recently reporting XE is showing more severity in children. How Malaysia should deal with the vaccination program?
I think that the recommendation here is one who should receive a booster dose. And in that sense, that is what the roadmap, if you see, supports. If you have had, especially your vaccination, your population about 60 years of age, fully vaccinated, that means that you have over 80% of the people vaccinated in that age group. Those are the people that you should start giving a booster before you go down in age. If you have enough vaccine that you can do that and at the same time start giving a booster to people 50 and above, 40 and above, 30 and above, then this grading down allows you then to start immunizing a younger population. The big question is, when do we start vaccinating our children? And in that sense, I insist, being a pediatrician, that we need to start as soon as we have vaccines available. And for that, we must realize that there are very few products that can be used in children from 5 to 11 years of age. In fact, the WHO has only one pre-qualified vaccine in that sense, one vaccine that has CUL, which is the Pfizer vaccine, because none of the others have given the WHO the necessary information to be able to change the things. We will hear the data coming out of Chile for the idea of using in inactivated vaccine up to 3 years of age, but those are new things coming up that we need to do. But below 5 years, we don't have anything. And that is the group that we're really worried about, because those are the smallest children that in a sense would be the ones more liable to become infected if we had a new variant, as we have seen with Omicron, that you correctly said is infecting our younger population. The other group that needs to be protected is the health force. And the health force is not just the health workers, it's everybody who contributes to that, from the man who deals with the security at the entrance, to the person who cleans, to the person who prepares the food, the x-rays, the immunotherapy, the radiotherapy. Everybody in a health situation needs to be protected. And those are a priority group because those are the ones that help everybody else. So in that sense, I don't know exactly the situation in Malaysia, but I would say that as we saw for the Western Pacific, in which you are included, your vaccination rate has allowed you to get to this level of protection without a huge amount of infection, as you have seen in other parts of the world. Therefore, the only way to maintain that immunity, looking at the way that the vaccines wane over time, is to start having a booster program that is very effective, as with the initial part of the vaccination. If you saw in China, the difference between Hong Kong and the rest of China was obvious in the number of cases. In Hong Kong, the vaccination of all the people over 60 was extremely low. Less than 30% of the population over 60 were vaccinated, and therefore that is where you had the highest number of deaths now that they had this huge Omicron surge that they hadn't seen before. If you compare that at the same time with what happened in New Zealand, that has a rate of vaccination above 90% for that population, the number of deaths there were very, very few. So in that sense, I think the evidence is showing us the way we need to move on. So in that sense, the availability, the purchasing, and the use of the vaccines are an essential component to be able to maintain the level of protection in the population.
I agree with you, Dr. Hendro. Thank you. And just a comment that Sinovac vaccine is also approved 5 years and above in Malaysia, along with 14 other countries who are vaccinated, and some of the countries, I think 6 of them already started vaccinating 3 and above, including Chile, for which we will see the data. And we have very promising results from the study, which is go all the way to 6 months of age. I think Dr. Gao will indicate on that study results, which will be coming up soon. So, since there are no more questions and we have already taken the time required, I would like to thank you, Dr. Alejandro, so much. I know it's too late, almost midnight in Mexico, so you can stay if you still feel, if you are not so tired. But if you would like to, we can let you go and relax. Thank you so much, Doctor.
Thank you very much. I'll be happy to stay and hear Dr. Gao, of course. Thank
Okay.
you.
Thank you. Okay, our next speaker is Dr. Gao. Dr. Gao, the floor is all yours.
Yes, can you hear me now?
Yes, we can hear and see the screen.
Okay. Okay, thank you. So it's my great pleasure to be here to share some evidence from Sinovac and also from Chile and Hong Kong, I mean, around the world. So just I will start a very brief introduction about Sinovac. In fact, Sinovac it has a history of 20 years. It's not a new company. So at the very beginning, Sinovac has focused on the research and development of vaccines for infectious disease. And Sinovac is always on the front line to fight against the new infectious disease. If you take a look at this timeline, so at the very beginning, Sinovac has a hepatitis A vaccine. Then they have a vaccine against SARS, and also other vaccines like influenza, hand, foot, mouth disease, which we call that enterovirus 71 vaccine. And also we have SIPV vaccines. So in 2020, we have launched the vaccine against COVID-19, which we call that CoronaVac. So from this figure, you can see that it's not a new vaccine that developed with other with any basis. So it's for CoronaVac. In fact, it's an effort of 20 years. And also for CoronaVac, it's also a success of scientific technology announcement in China and the world. So here you can see so far we have more than 200 papers focused on the safety, efficacy, and effectiveness of CoronaVac around the world. And for Sinovac, we have published our results on Science for preclinical study and also some phase 1, phase 2 clinical trial results in Lancet and also in the Journal of Medicine. So that's just a brief introduction about the Sinovac, that to back up that for CoronaVac, we have a lot of scientific data and paper to ensure the safety and also the effectiveness of the product. So today I will cover 3 topics. The first is the safety and immunogenicity of CoronaVac as of 2 doses and also as a booster dose among children and adolescents. Then share some evidence from Chile on the effectiveness of CoronaVac among children and adolescents. Then we'll give you an update about effectiveness of CoronaVac during Hong Kong Omicron outbreak. So first, we will start the phase 1, phase 2 clinical trial among children and adolescents in China. This study started last year in October. So the objective of this trial is to evaluate the safety and tolerance of the different dosages of vaccine among children and adolescents, to also determine the appropriate dosage for further clinical trial. So this is the basic design of phase 1, phase 2. For phase 1, there are totally 72 volunteers. For phase 2, there are about 480 volunteers. There difference between these 2 stages that for phase 2, we have a placebo control group, and both studies had the 2 dosage of the CoronaVac, of the vaccine. One low dosage is about 1.5 microgram, and also a middle dosage is about 3 microgram. So totally, there are about 550 volunteers in this phase 1, phase 2 clinical trial among children and adolescents. So the result of the safety turned out that the overall incidence of adverse reaction was about 20 to 30%. It's very common for a new vaccine. And the most adverse reaction were grade 1 and grade 2 in severity. So very few grade 3 AR was reported. And except for injection site pain, no significant difference in the prevalence of other adverse reactions among the 3 groups. I mean, the 3 different age groups, there's no significant difference. And also the most common reaction were injection site pain and fever. So most importantly, no serious adverse reaction related to the vaccine has been identified or reported. So different dosages of CoronaVac are safe among the different age groups. So this is the safety profile of 2 doses of CoronaVac among children and adolescents. So for the immunogenicity, the overall means the immunogenicity among different age groups may be a little different, but the positive rate is over 96% for each groups, whether it's age different groups or different dosage groups. So, and also for the GMT, I mean for the antibody level, neutralizing antibody level against wild type SARS-CoV-2 virus, was significantly higher than significantly high is significantly higher. Not if we compare the middle dosage to the low dosages, and we take further look at the GMT level here. You can see a kernel-like induced human response in the children and adolescent ages 3 to 17 years old if you compare before the vaccination. So this is basic information about the safety and immunogenicity of the two-dose kernel-like in phase 1, phase 2 clinical trial. So we all know that there is a new situation now, and a lot of country and region think about both dose of among children and adolescents for of COVID-19 vaccines. So based on the study in phase 1, phase 2, so Sanofi just sponsored a clinical trial focused on both dose or third dose of kernel-like among children and adolescents. So the design is similar as the study just mentioned. We have two group of dosage. The lower is about just is 1.5 microgram, and the middle series is 3 microgram. So for the schedule, the primary series means the interval between the first dose and second dose is 28 days. And for the both dose, there are two groups. For the one is 10 months, the other is 12 months. So for the total sample size is about 346. The result of safety turned out that the overall incidence rate is about 7.8%, and all adverse reaction are grade 1, grade 2 in severity, and also no serious adverse reaction were reported during this clinical trial. And the injection site pain is also the most common adverse reaction. So the whole picture of safety profile for both the doses of kernel-like looks good. And for the immunogenicity, first we focused on the original strain, or we call the Wuhan strain, or the white type strain. It also shows that for the positive rate of neutralizing antibody among different age groups is 100%. For the neutralizing antibodies, after both dose, there is a 30-fold increase if we compare it after third dose. This means after 2 doses of kernel-like, an immune memory has been built. So if we get another third dose, another kernel-like, the antibody level can increase very quickly, and also get a higher level of neutralizing antibody to which can prevent the infection. And also we compared the GMT after 2 doses and both doses. So we can see there about around 5 times increase after both doses if we compare the same time point, after 2 doses and after both doses of kernel-like. So this is the result when talking about focus on the original strain or white type strain of SARS-CoV-2. So we all know there's now Omicron variant is circulating in the real world and in almost all regions and countries. So we also did a neutralizing analysis with Omicron strain. So the result turned out to be that the positive rate of neutralizing antibody was 90%, over 90% for 2 middle dosage groups. So here we refer that there is a 10 months interval and 12 months interval. So both have a high positive rate. And for the age group of 3 to 5 years old, the positive rates of neutralizing antibody was 100%. So this result also shows that 3 doses of coronavirus or after both doses of coronavirus can have a very good neutralizing antibody levels, which can as to prevent Omicron variant. So this is the latest result of both doses of immunogenicity, and also now I will move to another part, that some evidence from Chile on I think most of them on effectiveness of coronavirus, and also as a result of preventing SARS-CoV-2 Omicron variant among children and adolescents. So first, I will just a brief about the background of Chile. So I will focus on that. Chile has a well-designed health information system. This means they have a national insurance system which covers more than 80% of citizens of Chile. So in this system, they collect the health status of the residents, and also they connect this record to the vaccination record. So that means it's a basis to assess the efficacy and also the effectiveness of COVID-19 vaccines, not just inactivated vaccine, but also other vaccines like mRNA vaccines. So here's the situation, COVID-19 situation in Chile. You can see here, if it is the bottom part here. So in Chile, there are several COVID-19 variants here. So in different time, there are different COVID-19 variants. So that means a very good field for COVID-19 vaccines for the public health authorities to assess the effectiveness of COVID-19 vaccine in the real world. So here, this is a result that published in New England Journal of Medicine. So here you can see this is the analysis based on 10 million people which have been recorded in the national insurance system. And among those people, there are about more than 4 million people have completed 2 doses of coronavirus vaccine. So the researcher from MOH in Chile, they compare the difference between the people vaccinated and unvaccinated and the people who vaccinated with coronavirus. So they have the result of the performance in the real world of 2 doses of coronavirus for adults. So here we can see the result that for overall of effectiveness to prevent systemic COVID-19 disease is about 65%. The effectiveness of protecting hospitalization is about 87%. To protecting ICU admission is about 90%. To prevent deaths, the effectiveness of 2 doses of coronavirus among adults is about 86%. So this is the result of 2 doses of coronavirus among adults to prevent SARS-CoV-2 virus infection. So during this study, the predominant variant is Gamma, is not Delta or Omicron. But this study has been published in New England Journal of Medicine. That means the quality of database and also the method used by MOH have been recognized by the top scientists of the world. So this is just the result published in New England Journal, but in fact, the researcher in MOH had done a series of analyses to assess the effectiveness of 2 doses of coronavirus. Here in the table, you can see there are 4 analyses of effectiveness of chronoic. So all those continuous analysis shows that 2 doses of chronoic has a very good protection for hospitalization cases, ICU cases, and deaths. So they all use the same method just mentioned in the New England Journal of Medicine. So use the same database and same method. The researchers in MOH in Chile, they did similar analysis focused on children and adolescents. So this graph shows that there are 3 analyses of 2 doses of chronoic among children and adolescents. So for the, I will focus on 2 studies which have been released in the preprint website. So this is a analysis of 2 doses of chronoic among children and adolescents aged 6 to 16 years. So when this study is conducted, the predominant strain is Delta variant. So this means that the result is can reflect the effectiveness under a situation that Delta variant is circulating in the real world. So the study involved about 2 million children and adolescents in the database. So it's a study period between June 27 to January 12 this year. So it found that the just vaccine effectiveness for children and adolescents with 2 doses of chronoic was 94% for overall or for symptomatic COVID-19 infectious disease, and 91% to prevent hospitalization, and 93% to prevent ICU admission. So this is a very solid evidence to show that 2 doses of chronoic works very well, or performs very well when adult as a predominant strain in Chile. And also this is a study from real world. And also the research in MOH in Chile, they take it further because more and more evidence has shown that the children between under 5 years can get infected and can be sick, and even there's some serious case reported, or even death case reported. So they did a further assessment focused on children between 3 to 5 years old. So for this analysis, it's conducted between December 3rd, 2020 to February 26th this year. So during this study period, Omicron variant is a predominant strain. That means the result from this analysis reflect the effectiveness of 2 doses of chronoic under the situation that Omicron is a predominant strain. So the study found that 14 days after administering 2 doses of chronoic, the protection effect against COVID-19 infection is 38%. The effectiveness to prevent hospitalization among children between 3 to 5 years old is 64%. The effectiveness to prevent ICU cases is about 17%. So this is a real world data to confirm that 2 doses of chronoic performs well among children between 3 to 5 years old to prevent especially severe disease like hospitalization and ICU admission. And also some maybe notice that there's no data about the death, just because there's no available data can be used to estimate the protection of rate, because only 2 death cases be reported during the study period. So this is a very strong evidence to show that 2-dose of coronaviric works during Omicron as a predominant strain in the real world. And this is a serious study to focus on children and adolescents in Chile. And also the scientists or the researcher in MOH, they did a further analysis of the third dose of coronaviric. So this is analysis among the adult or people aged 16 years old. The sample size is 11 million people. So from the result released by Chile MOH, the effectiveness of both doses of coronaviric can increase the effectiveness against hospitalization from 84% to 88%. And both doses of coronaviric for adult can increase the effectiveness against COVID-19, for symptom infection from 56% to 80%. So this is evidence to show that both doses of coronaviric performs very well among adults to prevent the COVID-19 infection or disease. So this real-world study or real-world evidence from Chile to support that whether it's for children and adolescents or for adults, 2 doses of coronaviric can effectively prevent severe disease like hospitalizations, ICU admissions, and deaths. And also we have the data that both doses of coronaviric works also well among adults to prevent disease. So this is the result evidence that's from Chile, because Chile has some, very good information system that connect the health data information and a record of vaccination information. So they just work on that and did a serious analysis of 2 doses and 3rd dose of coronaviric to make sure that coronaviric can help Chile to protect their people. So the result turned out that 2 doses of coronaviric or 3rd dose of coronaviric did work well in the real world in Chile. And also, now I will move to the last part of the presentation, just to show some evidence from Hong Kong about the effectiveness of coronaviric. So this is the epi curve to show that the situation or the trends of COVID-19 outbreak in Hong Kong. So from the beginning of this year, there's a quick increase of COVID-19 cases in Hong Kong. As particularly, there quickly increase of number of death cases of COVID-19 in Hong Kong. So which caused, I think, the very big outbreak of COVID-19 in not just in Hong Kong, but in Asia region, because the number of deaths now is over 8,000. The total number of cases of infections is more than 1 billion in the region of Hong Kong. And there's some very important messages when we focus on the outbreak of Hong Kong. the majority of the severe COVID-19 cases, like deaths, have occurred in unvaccinated individuals, and also specifically in unvaccinated elderly people. So if we take a further look, over 95% deaths were persons over 60 years old. And the reduction of case fatality rate across all age, even after one dose. And if you compare the people unvaccinated and vaccinated, so we can find that it's a much lower fatality rate for those people who have get vaccinated. So this is very important because that message, not lesson from Hong Kong. And if we, and not only in Hong Kong, WHO, US CDC, and China CDC published at the same time about the report of Hong Kong Omicron outbreak. So the report analyzes the mortality rate and the vaccine coverage in Hong Kong during this Omicron outbreak. So it's very clear that the people, the people unvaccinated has a much higher mortality risk than people who have been vaccinated, whether it's 1 dose, 2 dose, or 3 dose. So this is very important messages we got from Hong Kong for the world, for China, that higher mortality risk was driven by low vaccination coverage among older adults. So this is a overall picture of the Hong Kong, the Omicron outbreak in Hong Kong. So the Hong Kong University, they use the data from the government, from the Hong Kong Health Authority. They connect the database of cases and infection, and also the database of vaccination record. They did a systematic assessment on the relation between the health status and the vaccination for all the COVID-19 vaccines in Hong Kong market. So that's not just inactivated vaccine, but also Pfizer and mRNA vaccines. So this is some basic method or study design of this analysis. So the analysis focused on the cases between December 31, 2021 to the 8th of March of this year. So in total, there are almost 500,000 cases included in this analysis. So the result tends to be that coronavirus can effectively prevent severe disease and death during the current Hong Kong Omicron outbreak. Here you can see from the data in the table. This table is from the report released by Hong Kong University last month. From this table you can see for 2 doses of coronavirus, it can prevent all the effectiveness of the 2 doses of coronavirus to prevent severe death for people between 20 to 60 years old is over 90%. For the elderly people, means over 60 years old, the effectiveness to prevent severe disease or death is more than 70%. So for 3 doses of coronavac, I mean both doses of coronavac, it can prevent effectively against death and severe. So if we take the data and further, it's almost over 98%. So this is a very solid data to show that 2 doses of coronavac can effectively prevent severe disease and death under the situation that Omicron as a predominant strain. So these results have been released, and also a lot of people have get the key messages from this study that 2 doses of coronavac works a performance very well during the Omicron period, or Omicron as a predominant variant strain. So this is very important messages give us, and also we have a I'm very confident that 2 doses of coronavac or 3 doses of coronavac can also be expected that works very well in the real world to prevent severe disease and death among children and adolescents. And if we further think about the evidence from Chile, that among children between 6 to 16 and 3 to 5 years old, 2 doses of coronavac performs very well. And at last, I would like to share that we also have a phase 3 trial of 2 doses of coronavac among children and adolescents. So it's ongoing, and the preliminary result shows that 2 doses of coronavac among children and adolescents have very good preliminary safety result. And the result is very similar to the result we have from phase 1, phase 2 clinical trial in China, which I just mentioned at the beginning of this presentation. So it also suggests that 2 doses of coronavac had good safety in healthy people and also in different races around the world. And also because the safety of our product or 2 doses of coronavac is also the priorities that we care. So we also did a post-marketing safety monitoring in China. This is a company-sponsored observation study. So basically, we have 9 or 6 provinces in China. So we identified more than 33,000 participants, children and adolescents. We closely monitor the health status of the volunteers after vaccination with 2 doses of coronavac or 1 dose of coronavac to see if there are any potential safety signal. So far, based on the interim analysis, 2 doses of coronavac showed a good safety in this large-scale population among the children, between 3 years to 17 years old. And the incidence of an adverse reaction event in this study was 2.17%, and most adverse event was solid and grade 1, and the injection site pain is the most common symptom. And most adverse reaction with 7 days after vaccination, and the higher incidence of the adverse events after first dose. So based on this interim analysis, it also shows that 2 doses of coronavac is very safe among children and adolescents between 3 to 17 years old. And also, so far, CoronaVac has been granted EUA and conditional approval in 14 countries and regions around the world. And more than 280 million doses has been administered around for children and adolescents around the world to prevent severe disease and death. And in total, there have been 61 countries and regions around the world have granted CoronaVac EUA or conditional approval as an important tool to fight against the pandemic. So thus, in summary, real-world evidence from Chile has confirmed that 2 doses of CoronaVac among children, among adults, can effectively prevent COVID-19 disease caused by COVID-19. And also, real-world study or real-world evidence from Hong Kong demonstrates that 2 doses of CoronaVac or 3 doses of CoronaVac can effectively prevent severe disease and death caused by Omicron variant. And so far, 14 countries and regions granted CoronaVac EUA or conditional approval among children, adolescents between 3 to 13 years old. And 61 countries and regions and international organizations around the world have granted CoronaVac EUA or conditional approval. And I also believe that more studies on efficacy and effectiveness and safety of CoronaVac among children and adolescents will be conducted, and more evidence will be coming. So thanks. This is what I want to share with you. Thank you.
Thank you. Thank you, Dr. Gao, for your presentation, and it's very reassuring looking at the safety data from China and also Hong Kong data on effectiveness, that we know the 2 doses and the 3 doses are highly effective. I have a question from the booster immunogenicity study. You have done a booster at 10 months and 12 months, and we see from the antibody kinetics studies that they go down up to 3 months and 6 months after 2 doses. And we have also seen that the booster can increase the neutralizing antibody against Omicrons very significantly. So moving forward, what would be the recommendation for pediatric age group booster timing? Is it after 3 months, or can be given as early as possible so that the countries are prepared for the Omicron wave, which are still expected to come? Like Malaysia, we are still in the Omicron wave. And what would be the right timing for this booster dose in pediatric population?
Yes, this is a very good and very important question when talking about the booster dose among for children and adolescents. So in our study, our clinical trial, we use 10 months and 12 months because at the very beginning of this study, when we did the study design, we have seen that there is a strong immune response among children and adolescents if compared with adult and elderly people. So we think that maybe we should have a longer interval between the 2nd dose and 3rd dose. So that is works very well. But when we're talking about the interval between 2nd dose and the 3rd dose in different countries, different regions, it must be considered the situation in the country. So I know, in fact, some regions or countries have shortened the interval between the 2nd dose and the 3rd dose or both dose from maybe 6 months to 3 months or 5 months. So because they want a robust of antibody level to after both dose as a response to the Omicron variant, because that there have been several months past, there are a little bit of waning of antibody level after 2 doses of coronavirus or other type of COVID-19 vaccines. So it's a common phenomenon for COVID-19 vaccines. So it's not just for inactive vaccines. So shorten the interval between the second dose and the third dose is necessary to fight against the COVID-19, regardless of the situation in each country and region.
Well, I think you rightly said that maybe we don't have to, depends on the country, the epidemiology of the disease and how Omicron is behaving, as also highlighted by Dr. Alejandro earlier. A country may have to decide at what point they can boost, especially for Omicron variant, which is causing surge currently in Malaysia as well as other countries. Okay, so we have a few more questions. Okay, so okay, thank you, Dr. Gao. I will like to invite now Dr. C. Kui Cheng from Sungai Buloh Hospital to give the final presentation for today. Dr. C, the floor is all yours.
Thank you, Dr. Ajit, and good afternoon to everyone. Are you able to hear me?
Yes, yes, very clearly.
Yes, the slides will be, yeah. Okay, I think the previous two speakers have alluded very well to the current situation globally and also the role of vaccination, especially the Sinovac vaccine. And we actually part of the phase 3 trial in Malaysia in Sungai Buloh Hospital, which we are still at the moment in the middle of the interim analysis. Okay, the next slide. The next slide, please. Yeah. Okay, so this, all right. So we will talk about the introduction, the clinical manifestations of COVID-19 in children, especially the Omicron variant, vaccinations in children, and some take-home message. Next slide. Now, it started back, as everyone know, in December 2020 in Wuhan. At the time in Malaysia, we had a high seasonal influenza epidemic, if everyone still remembers. And we were worried that time because usually this kind of things signals that something else is happening worldwide. And the influenza epidemic at that time was higher than usual, and we were seeing a lot of typical manifestations of the influenza infection. And we had our first pediatric patient in Malaysia arrive on the 25th of January. That was the first day of Chinese New Year in Malaysia. And it was a family from Wuhan, China, who came in through Singapore. And after that, we were immersed as ground zero in Malaysia until now. Of course, before that, we had a lot of involvement with the H1N1 in 2009. Then the SARS in 2012, although it didn't cross over from Singapore to us. We had a few MERS-CoV. We were even ready for Ebola that time. It didn't come to our shores. So Sungai Buloh Hospital has always been at the forefront, a ground zero of the infectious disease in Malaysia. And of course, it was declared later on pandemic in March that year. Next slide. This was our publication of the first series in that year itself of the 4 pediatric cases in Malaysia, which was the Wuhan family that came to our shores. We didn't have much scientific data to back us up at that time. Everything was being learned as we get more data every day from China. And of course, that time, US and UK was still spared from the virus. So we actually paralleled the best evidence we had at the time from the team from China, which actually mentored us a lot during that time. The team even came from Guangzhou, China, to actually mentor us in the whole of Malaysia during this time. So a lot of our initial management and data was actually from China before CDC and also the Europe data came in. Next. All right, we are still in the middle. We have already not used up all the Greek alphabets. We still know that there are variants coming on board, but at the moment, it feels that we may be reaching the end game, as what Dr. Alejandro says. Next, please. All right, so it has close to about actually 72 mutations compared to the previous variants, and this is why it is so transmissible. It has immune escape mechanism, and this is why it's quite challenging actually to handle the Omicron. Although we were actually also inundated when we had the Delta variant last year, and let's see what this new variant brings along. Next slide, please. We knew about it when the South Africans started to report in their journals a new variant that came upon their shores back in November 2021. And soon enough, by the winters in the northern continent, every big Western countries was reporting their cases. But actually, it came down very fast after that. So we were actually ready, and we actually modeled ourselves these times after the previous experience with Delta and also the wild type variants back in 2020. Next. The proposed routes of transmission, we knew when it started, it was droplets. And then as we went on with the patients management in our hospitals, we found that it was airborne. And true enough, the healthcare workers and also the patients were also getting it even from termites. Next, please. Now, Omicron has a shorter incubation period compared to Delta. And that's how it is, you know, it's a bit milder, but next slide, please. But because of that, we find that the use of RTKs are much better and much faster. It gives us more leeway to work with the patients and also our healthcare staff who are getting more infected during the Omicron phase. So the way forward, as we know it now, is laboratory-based RTK tests and also self-testing. Next. All right, so because of this uniqueness of the Omicron variant, now we have you know, isolation from 5 days to 7 days or 10 days, depending on your severity. And we have already offered the optional rapid test for the public to use, and also it helps a lot in the hospitals at the moment, especially for the healthcare workers. Next. When it started, the R0, the basic reproduction number for COVID-19 was just about 2.5. It was somewhere, you know, between the influenza and, of course, the more infectious tuberculosis. But next slide. But for the Omicron, we found that it's actually 3 to 4 times more infectious compared to Delta. The R0 is expected to be up to about 8 to 15 compared to Delta, which is about 6. So a person with Delta will probably just infect about 5 persons around him. But with Omicron, it can go up to about 15 persons around you. So that's how severe and how fast it can actually infect the persons around you. Next, please. When we first started, we started to look into the lungs of the patients, especially the adult patients and the senior citizens. You know, we find that, you know, they have very bad ARDS, and this is how the whole cascades of the cytokine storms affect the lungs, causing it to you know, in the end, be attacked by all the immune cells in the system and leading to death. But for the Omicron, it is a bit different. It is more adapted to its place in the upper airways, and it has an multiplication rate of 70 times more faster than compared to Delta in the upper airways, leading to clinical manifestations, which I'll talk later, which are a bit different than Delta. Next slide, please. Next slide. All right, we have used the clinical staging as everyone is familiar with it. But bear in mind, you know, the manifestations of Omicron is not really limited to the lungs this time compared to Delta. Next. All right, this is our publications last year, focusing on the 2020 and also the 2021 part of the year. And the initial part of the patients actually showed a lot of symptoms associated with upper airway and also extrapulmonary symptoms. But most of them were actually mild, and we didn't have much problem with 2020. The issue started back in 2021 when the patients were more ill with the Delta variant. Next, please. Now, the Omicron variant, as opposed to the Delta and also the wild type or the Alpha variant previously, is a bit more friendlier kind of virus. It coexists with a lot of other bacteria and also viruses, especially Mycoplasma, RSV, especially in Malaysia. We have all year round RSV prevalence and also other normal type of infection viruses that you will find in the community. So this is a very coexistent virus compared to Delta, which is more, a single kind of virus infection, and also the other viruses before it. Next slide, please. Now, the CNS manifestations in Omicron has been elucidated in the past, during the Delta wave itself, but it became more prominent during the Omicron wave. There's a lot of case reports from Eastern and also Western countries regarding CNS manifestations in the Omicron infection in children. But all of them actually, most of them actually has a good outcome in the end. Next slide, please. Now, in our hospital, when the Omicron wave first started in early February, we find that there is a lot of febrile seizures presenting to our emergency department and also getting admitted. And of course, when they are positive for COVID-19, they are actually centripetally sent to my hospital, which is the strategy that we are having in Klang Valley, the biggest part of the most populated part of Malaysia, where it's all focused in Hospital Sungai Buloh, so that the non-COVID cases can actually be managed without much interruptions in the other hospitals. So as you can see, in February, where there was a peak rise in the COVID-19 cases, the Omicron variant, you can see that besides simple febrile seizures, we also have complex febrile seizures and also meningoencephalitis in our patients. And apart from that, the populations which we had underlying epilepsy or seizures also had breakthrough seizures or fever-provoked seizures. And there was also a few cases of status epilepticus. Now, what I want to conclude here is that you have to be very careful when you have febrile seizures in this group of patients. And when they have atypical presentations in terms of age, if your age is actually, more than 5 years old and you're still diagnosing the patient as febrile seizures, you have to think back twice, because it's very unusual to have those kinds of age of presentations for febrile seizures. Number two, if they are not fully conscious or regain some sort of consciousness in between the seizures, especially with complex ones or the ones with multiple seizures, then you're probably not dealing with a simple febrile seizure. And be careful about these cases, because they could be encephalopathic, what we call COVID-19 related encephalopathy, or the mnemonic is called CORE, C-O-R-E. So these kind of cases, you have to actually get a pediatric consult or a more senior consult from your emergency department before you actually call it a febrile seizure. And we have a few cases where they actually turn out to be ADEM or an acute demyelinating encephalomyelitis of childhood, and those very ill patients, which you actually need to actually refer early to a tertiary center which deals with these cases. All right, and the third one is also to make sure that these patients actually are seen by a senior staff of your emergency department before you refer out, because cases have actually been referred in a very ill state when the patients arrives at the emergency department. So be very careful with seizures in the Omicron phase. Next one, please. And in March, we still have a lot of febrile seizures, and it's the same thing. We only are seeing a bit less of these cases in April as we go down the escalation slope. Next one, please. Okay, in the same time, we also had a lot of ICU admissions for those patients which was referred to our hospital. And as you can see, some of them even have intracranial bleeding after the seizures, which was detected on CT scan. Yes, yeah, the third thing I wanted to say just now was the CNS findings. Please do a complete CNS findings examination on this patient with febrile seizures. If you find upper motor neuron findings, please rethink your febrile seizure diagnosis again, right? Okay, Next one. Yes, so at the time when we look at some of the data from Seattle, this was from Seattle Children's Hospital. You also find that most of the patients that presented in the winter months of Seattle actually shows more upper airway issues such as croup. Next. Okay, and as you can see here, that the admissions and the way they were treated, actually it was more than the usual cases that you would actually see compared to the Delta surge which they had last year. So it attacks more of the upper airways compared to the lower airways. And this is something we were actually adapting at the time, and we were ready with these manifestations which was reported from the Western countries, the croup, the CNS manifestations. So our team was told to actually to be more ready for this group of children presenting with atypical presentations compared to the Delta variant last year. Next. Okay, and the other ones that we found that was reported overseas, especially by this group in Italy, is that they also had GI symptoms, especially with vomiting and also severe diarrhea. And true enough, during these last 2 months, we also had a lot of acute gastroenteritis, which was needing admissions with intravenous drip and also bit longer length of stay compared to previously seen in the ones that we reported last year in 2020 and 2021. Next, please. Okay, and then you can see that there was also a few of them which was also that underwent surgery and was referred to the surgical team because of suspicions of appendicitis and also pancreatitis, especially in the younger age group where the diagnosis can be quite subtle and complicated at times, depending on whether it's a surgical or a medical condition. And some of them actually had undergone surgery, ending up with a white lily in the end, normal appendix. Next. Okay, so we can see that the clinical parameters are a bit different, atypical compared to the ones that presented earlier with the wild type or the Delta variant, where the predominant one was mainly fever and also lung issues. Whereas this one presented more with GI symptoms and also atypical presentations, and also an increase in the biomarkers. Next. All right, next. So we move on to our statistics that we had when we first prepared for the Omicron surge. We had a lull in the storm after the Delta wave settled down around October onwards. So November, December, and January was with low cases, and everyone thought that we would not be affected by the Omicron. But we know from the reports from South Africa and US CDC that it will come to our shores eventually. And this was the model that we predicted at the time, that based on the R0 of 1.6, that we would actually hit about 30,000 cases. And true enough, we hit it very nicely in February and March. Next one. So we had to again go back to our upscaling of our disaster management, where we actually downscaled after the Delta cases came down. So this time around, we actually increased the involvement of the virtual CACs, which was, as you know, was quite overwhelmed when we had the Delta wave. So this time we used the virtual CACs, or what we call the COVID-19 assessment centers in this round alone. And we also started the pick kits for the children on the 5th of February. If I'm not mistaken, that was the 3rd day of Chinese New Year. Yeah. And we started with the community dosages, and we're a bit different here, that we use an interval of 2 months in Malaysia instead. And of course, at the same time, we had to again open up the MAEPS, the low risk quarantine center again for the increase in expected increase in patients during this time. Next. And as you can see, this is what we call EW stands for Epidemiology Week. Sorry, this is in Bahasa Melayu. And as you can see, for the cases over the Epidemiology Week, it actually peaked around the 5th to 6th Epidemiology Week. That means in the middle of February this year. And yeah, next one, please. And as you can see, as we enter February, the number of cases that was admitted also increased drastically as we started the Omicron surge here. Next, please. And most of them were actually in the category 1s and 2s, as we expected. But the sheer numbers of it actually is the ones that we are worried about. As you know, one of the markers for infection in children is what we call a secondary attack rate, or the number of household contacts that will actually get the infection itself. And as for Omicron, it's actually stipulated that you can get up to about 50% of the household contacts to be positive during this Omicron wave. And we know that most of our children actually comes from very extended families in around Malaysia, and especially in very overpopulated states like Selangor, where we are. So true enough, the numbers actually surge up very much. And when you have 30,000, although even 1% of them are actually just category 1 or category 2, you are dealing with close to about 300 patients per day. So that is enough to break any camel's back. Next. Okay, so this is the latest reports that we have from the COVID Now database, where the positivity rate is still coming down. It reached a peak of about 15%. Now it's about 12.6%. We still have cases ranging between 4,000 to 5,000 every day. And I'll tell you later why we expect the cases to remain around this number for the next few weeks or months to come. Next. Of course, the number of cumulative deaths are about 30,000, but it has come down a lot. And at the moment, as was shown from the data from the first two speakers, the number of deaths are actually affecting more of the 60 years and above. The number of patients ventilated and the use of ICU beds have reduced remarkably. And we know that, in Omicron, they don't actually, overwhelm your ICUs. They just overwhelm your public health services a lot. Next. All right. Sadly enough, we have deaths in the Omicron wave. If you see these two columns here, from 0 to 11 years old, if you count all of them, it's close to about 38 deaths so far. But the majority of deaths in the red, the three columns at my left, at my right here, is mainly those 60 years and above. And these are the ones contributing to the majority of the deaths in the Omicron wave, right? And true enough, the percentage doesn't tell you much, but the sheer absolute numbers actually tell you that there are deaths, and it's very sad when you have deaths in the pediatric population. And hence that's why for this group, at least this second bar here, there's something we can do. And I think it goes with the spirit of the talk today, that we need to ramp up the vaccinations in this group. Next. Okay, the case fatality rate, as you know, it's low, but any deaths, like I've said before, is actually a tragedy, especially when we know that the Omicron is actually a vaccine preventable disease. All right, next. Okay, and this is the comparison between the patients that we had in the last 4 waves. And as you know here, that those with comorbidities will actually be more at risk of actually getting severe disease, admitted to ICU, and have a higher risk of death itself. Next. And even in US, before the Omicron hit us in Malaysia, we find that those even the children with comorbidities have a higher rate of hospitalization. Next. Okay, and when we compare the data from South Africa, from a district known as Shawane, again, it also shows that it affects children, especially those in the younger age group, with a predominance of upper airway symptoms and also GI symptoms and also CNS symptoms. So a lot of atypical presentations in this Omicron wave, and also afflicting those with comorbidities. Next. Okay, yeah, this is just a cumulative summary of the patients that they received there. And as you can see, a lot of them actually focus around seizures, GI symptoms, a bit on pneumonia, especially those with underlying comorbidities with chronic lung disease. But as you can see, the upper airways almost mimics the lower airways involvement here. Okay, something which is we don't see in the Delta wave last year. Next. Okay, same data also came from the COVIDNet report from United States for their winter admissions. Next. And it's the same, the children with comorbidities also got admitted a lot more these times. And there's reports that the EDs were all inundated with, overwhelmed with admissions from the pediatric age group. Next. Okay, that's the demographic of their age group. You can see that a lot of patients actually are from the pediatric age group. Next. Okay, next. All right, and the 3-day outcomes, of course, the risk is lower for the Omicron in terms of hospitalizations, ICU admissions, and mechanical ventilation compared to the Delta wave. Next. Okay, so this is our prediction for the upscaling of our beds in our hospitals, in the sense that if the cases reach up to about 19,000, how much additional beds that we need, and I'm sure we hit more than 19,000 during their predictions. We went up to almost like 30,000 in Malaysia. Next. Okay, this is where we worked in Selangor. As you can see, the numbers of the quarantine centers and the ICU hospitals were all, prepared for the increase in the numbers. But we did not use much of the ICU numbers, but actually we put a lot of the patients with comorbidities, and we need close monitoring because of non-pulmonary symptoms in this ICU itself. Next. As you can see in the Omicron phase, the symptoms that they presented with was mainly sore throat and less cough because it was more upper airway. The fever, although it was less common, it was actually higher in the Omicron phase, where the fever usually lasts about 2 to 3 days, but it's usually very high grade, and that's how it leads to a lot of febrile seizures. The loss of smell and also loss of taste is a bit less common in Omicron compared to Delta. So if you had, patients or adult patients who had these issues, it's quite rare compared to the Delta time. Next. Okay, that's all right. Next. Okay, next, that's okay. It's the same thing, yeah. All right, so the strategy at that time was actually to cluster the cases in central hospital that deals with COVID-19, especially for the pediatric ones. Up-ramp the PICKITS, the National Vaccination Program for Children, and also to have more communications with the public on the fears and anxiety about the Omicron wave. And I think we did much better this time compared to last year, where with the COVID now, we have real-time data on the latest infections in Malaysia. Next. All right, next. one thing that we found that we need to look at during the Delta and the Omicron wave is that we need to look at the heating, the ventilation, and air conditioning systems in our hospitals, whereby because the virus is airborne, if you do not have an effective ventilation system and also the need for negative pressure rooms, then you'll probably be infecting your staff more than compared to open air situations. And true enough, a lot of healthcare workers were infected because of the higher transmissibility of Omicron during this time. And a lot of them actually went on leave, and that caused a lot of human resource issues in the hospitals. But we knew the virus much better this time, and so we actually shortened their leave at the quarantine period at home if they are asymptomatic, and most of them were actually vaccinated and had received booster doses. So their quarantine period was shortened to close to about 5 days if they're asymptomatic, and they can come back and work, and so that the system will not collapse in the end. Next. And the other thing that we need to look at also is the oxygen supply to the your patients who need oxygen supplementation, especially in ICU, so that if you have an increase in patients with pulmonary symptoms or requires humidified high flow nasal oxygen, BiPAP, or even ventilation, your oxygen supply will not be compromised, because the design for most oxygen tubings and pipings in most hospitals are based on a decreased distal use point. That means as more patients use it, the less will actually be given to those who actually need it. So it's a complete shared policy. So you need to get your engineers to look at it, so that there are some innovations that you need to make so that the oxygen supply will not be disrupted. Next. Why do children fare better than adults? This might be true in year 2020 and 2021, but as most adults are now vaccinated, more children are getting it because they are the groups that are remained unvaccinated. But at the same time, they do have some innate immunity and also less ACE2 ACE2 receptor expression compared to adults, and that's actually quite protective in the children's in the pediatric age group. Next. And a good understanding of the viremia phase and also the inflammation phase is paramount to your management of the COVID-19 in children and also in adults. It's just the same for dengue and most infectious disease thing. You need to know when the viremia starts and when it ends, and when the inflammation starts and when it ends. And that's where you target your antivirals and your steroids. But it's not to say that we are using a lot of antivirals, steroids, or biologics in children. No, we are not using it a lot compared to adults. But this does give you a picture on what you need to do and what you don't have to do. So there's quite a fine balance between what is an infection versus what is a disease. You know, it's just like tuberculosis, between latent and active disease. Same thing with the COVID. You need to understand when is the patient having just an infection, but not the disease itself, and that makes a lot of gives you a lot of leeway when you want to manage your patients at home quarantined, and also to when you want to admit them. Next. So our criteria for admissions at the time was all category 3 to 5 disease, which was very minimal. There wasn't a lot in this category. Those who got admitted in this category were those with underlying comorbidities, especially those with asthma and those with underlying chronic lung disease, and so on and so forth. And the other thing that we admitted were those with age less than 1 year old, category 3 above, or pediatrics with significant comorbidities, especially those with underlying comorbidities, category 2 and above, that was having some issues at home, or they were needing some close monitoring for the next 2 to 3 days. And this actually helped us to keep the majority of the patients in the quarantine centers or at home this time. And this does help to reduce the number of places that we have to put up in the hospitals. Next. Okay, these are the I'm sure it's a non-exhaustive list of conditions that we actually need to look into. And most of these comorbidities are on its own quite vulnerable, not just to COVID-19, but also to the annual seasonal RSV infection, influenza infection, and other types of infection that normal kids get anyway during this time of the year. So with COVID on top of them, it's a good thing to actually refer these patients to the nearest hospital so that they can actually assess their risk factors and whether they actually need to be monitored at home or to be admitted. Next. Right, danger signs, I'm sure we all know the red flags in children. When you have all these things, then I'm sure we have a low threshold to actually refer them to the nearest hospital or to Hospital Sungai Buloh for admission. It's good when they are referred early so that they can escape more serious complications. And also their length of stay is just usually about 2 or 3 days. And usually we discharge them early this time. Next. All right, I will not go too much on the general management of these things. I'm sure it's all in the annex group. And like I said before, most of the treatment are actually symptomatic. And we use very little steroids, biologics, or even immunoglobulins in children. Next. The ones I'm a bit worried about, and I've talked in the past in my previous webinars, is on the multi-system inflammatory syndrome, MISC. We even see what we call MISN in neonates, multi-system inflammatory syndrome in neonates. And this is something which mimics the traditional Kawasaki disease in children, but it's more atypical rather than the full-blown Kawasaki's that we have in the past. Next. Right, it's something which we have already seen in 2020 during the initial part of the infection itself, and also in Delta last year, where we had close to about 137 cases of MISC during the Delta phase, and we had close to about, I think, 17 mortalities from it. And next. Now, the thing about MISC is that it has 2 different categories of diagnosis, one by the WHO and the other one by the American CDC. Next, please. It presents almost close like Kawasaki's, but usually it affects children up to, or even adolescents up to 21 years old. The one we are seeing here is from the ages of 5 to 11. And I think that's why I think it's can be prevented with good vaccination numbers in this age group. So it presents sometimes with non-purulent conjunctivitis and multi-organ involvement and also some rashes, but you don't see this quite typically in the Omicron wave compared to last year or even the years before that. So this time alone, we have to depend a lot on the biomarkers to actually make the diagnosis. Next, please. Okay, this is the ones that I was saying. We don't look too much at the Royal College criteria itself, but mainly it's between the CDCs and the WHOs. And as you can see, you need a combination of the fever, clinical symptoms, usually more than 2 organ involvements, the biomarkers itself, and an exclusion of other more pertinent or normal diagnosis in your setting. So if you have children which have persistent fever of more than 3 days, then you have to actually think of this condition, especially when most of our children would have preceding infection with COVID-19 in the past, whether it was through an RTK test or whether their family members had contacts. So everyone would have this history anyway at this time and place. So a high suspicion for MISC is very important at this stage. And although we are seeing a bit less compared to last month, but it's something which keeps bothering us all the time when you have a patient which is not well, and that he's probably you have to think of atypical MISCs at this stage. So bear this in mind with fever, and you have ruled out most of the other infections, and it's not getting well, especially the ones which still have constitutional symptoms such as not feeling well, not his usual self, and not responding to your treatments, whether symptomatic or not, then please refer to the nearest hospital so that the workup can be done. And as you can see, the diagnosis is not easy, especially when you're working in a primary care setting. Next, please. Okay, this is the one of the criteria that was put up by the American College of Rheumatology. It's good that if you can actually get this article, it's available online free, and you can actually have a flow chart on actually making the diagnosis itself and referring early. Next. Okay, all right, so hopefully it remains a rare manifestation of COVID-19 infection, but it's something that you always have to think of, especially now as we are still going in the endemic phase of the pandemic. Next. The cardiac manifestations of MISC is something which bothers us all the time because it involves a lot of teamwork with the cardiologists and also the monitoring of the patient in ICU. The ones which comes in a shocky state can actually have very low left ventricular functions, and they can actually come in a shocky state, just like dengue, you know, and they turn ill very fast. And sometimes you you lose the patient in the next 1 or 2 days. Right, next. Okay, next, please. All right, just looking at some of the comorbidities that we had for PICS ICU admissions, and as you can see, obesity is one of them that we sometimes overlook. The others I've talked about it before. There was also some relations with the increase of diabetes in children during the COVID-19 pandemic, but it's just a small correlation which they have not actually proven yet. But because most Malaysian children are actually obese, we have a close obesity rate, so close to about 40%. And that also is one of the risk factors for those who needs ICU admission. Same like dengue, you know, those obese children actually do worse than their counterparts which are not obese. Next. Okay, these were some of the red flags that they had looked at in the hospitalized children in Iran. And so those with comorbidities actually have a poorer outcome, especially in the under 1 and also under 5 age group. Next. Okay, and as you have more comorbidities, the death rate increases exponentially in their cohort. Next. And what is the evidence in long COVID in children? At the moment, the ones that we are following up in our clinic and the ones which have category 3, 4, and 5s actually have a very good outcome at the moment compared to adults, which actually are going to a different program for their rehabilitation, especially those with pulmonary issues. But at the moment, the Omicron ones which have actually been discharged are actually doing much better than the Delta cohort, which had more lung issues compared to which the Omicron has less lung issues at the moment. So yeah, so I think the jury is still out on this long COVID in children, and it may not be as severe as the ones that we are seeing in adults at the moment. Next. Okay, I also work as a neonatologist in the NICUs. And initially, we also had a few of the patients who actually had MISN, and these reports of the MISN was more elaborate from the group from India, where they found also a lot of atypical presentations in their babies, especially those with GI symptoms, and some even went on to have gut perforation and also needing a laparotomy and operations and so on and so forth. So it's something which we also see in the newborn period. Next, please. All right, you can look into their admission criteria for MISN, and yeah, it's something that you need to think of, especially when the patient presents to your NICU with atypical presentations and a history of COVID-19 infection in the maternal side and also in the postnatal period. Next. Okay, we have no issues with human milk in babies. So at the moment, some of them are actually pasteurized before being given to the babies. So breast milk is not a contraindication in our unit here and in most units. Next. Okay, so we now go to the vaccination in kids. So we started our pig kids on the 5th of February this year. And as we started this vaccination, there was a lot of reservations regarding kids, although we did very well before that for the adolescent group, with the rates of vaccination in the adolescent group now reaching more than 90%. So for the children, I think there was a lot of worries on the parental side when we started this. But as the Omicron wave came into play, a lot of parents actually became more receptive to the idea itself. And I think we are somewhere trying to ramp up more of this number of patients before we actually, what do you call it, give a limit on the vaccinations by next month. Next. So the objectives was actually to allow them to go back to school safely and to protect them from category 3, 4s, and 5s in children, and also to protect collateral infection among the preschool kids who cannot receive vaccination. Malaysia, being a Southeast Asian country, has a lot of extended families. So it's not just for the under 5s, but also for the senior citizens above 60, which stays in the same house. And so this is what we call the household contacts that are at risk of getting COVID-19 infection. Next. Okay, so the target was actually to hit about 60% of those 5 to 6 years old and up to 80% of the 7 to 11 years old. So that's how we started. And also we also have opportunistic vaccinations in those who comes to our hospital and in our clinics. So the target was actually close to about 3.6 million actually. Next. So the progress so far as of today, as you can see, for those 5 to 11 years old, we still need to improve on our rates here. So, and as you know, we have already included the Sinovac vaccination on the 7th of March. On a conditional authorization by the National Pharmaceutical Regulation Authorities. And as you can see, the more smaller states up north and you know, so on the East Coast, that the uptake is actually very dismal. So we have to work on improving these rates so that it can mirror the ones on the West Coast here. Although there still needs to be a lot of work to be done, especially when we started off with a 60 to 80% target. Next, please. As for the adolescents, I've told you just now, we have done very well. We have close to about 92% vaccination for the population all across the states. So, I mean, those states which were lagging behind has no issues actually vaccinating their adolescents. But when it comes to 5 to 11 years old, I think we have a lot of work to do in catching up in those numbers. Next, please. And as for the total doses administered for the whole country, as you can see, we increased a lot when we started back during the Delta wave. But as it goes on to this year, as you can see, the boosters have actually mellowed down a bit. All right. Next one, please. So the number of vaccinations given so far in Malaysia consists mainly of these 4 vaccines at the moment. Majority is the Comirnaty, and about a third is the Sinovac vaccine. And I think we have done away with the AstraZeneca vaccine. In fact, we donated some to another country a few days ago. Okay, next. Okay, so a lot of people were worried about the MISCs in children who receive a COVID-19 vaccine. But as you can see, the numbers of them actually getting MISCs was very low compared to the side effects or complications from the natural infection itself. Next. Okay, this was the Comirnaty vaccine effectiveness when it was first launched, and now we know with the Omicron variant that is, the vaccine effectiveness has actually dropped down, and you're more likely to still get the infection itself, but then it does protect very well against hospitalizations and ICU admissions. So we know that, because of the Omicron immune escape, you will still get infected, but you won't get a very serious disease. So that's the important thing to understand about the infection itself versus the disease itself. Next, please. All right, so the challenges that I feel that we need to address is how do we actually manage, a virus which is highly transmissible and has a very good immune escape, and we still are seeing a bit of the infection, and I think the numbers will plateau at around 4,000 to 5,000 for the next few weeks, because at the moment we have not addressed much of the 5 to 11 years old vaccination in Malaysia. The numbers are still almost, I think, less than half of what we planned initially. So we need to do more work on that. And as we relax most of our SOPs or standard operating procedures for the pandemic in Malaysia, in fact, we are now even talking about, the use or the disuse later on of the mask, the MySejahtera, then we are probably going to look at the plateauing of the cases as the number of vaccination rates in children are not climbing up. All right, so they are a vulnerable population, and we need to look at that. And we already started school now, so there's also another way whereby they will actually cause more infection to actually propagate from those congregation areas. Okay. And as I've said before, we need to look at the typical presentations of the Omicron infection and not the traditional lung involvements, because like I said, this virus coexists with other infections. It also likes the upper airways, and it presents with convulsions, GI symptoms, and also croup. All right, and I'm sure we will see more MIC cases as we go on, and we have to have a very high vigilance for the presentations. And it's good to actually get a pediatric consult when you are worried about this patient and it's not actually entering recovery after treatment. Next. All right, so we have talked about this one and endemic states in the past webinars with me. So yeah, so as you can see, I already thought it was not realistic at the time, and it's good that Dr. Alejandro actually shows Anthony Fauci's comment on it. It's not something that we need to par ourselves with, because it's not going to be realistic anyway. And looking at how Hong Kong and China is doing, with the zero COVID image, it is something, like I said, in the past, is it a mirage that you're going to achieve with this what they call it, tight restrictions on COVID-19? I think we have to move on with the COVID-19. We just have to live with it as we have done with the influenza and so on and so forth. So whether there'll be more variants of concern coming up with the BA1 and BA2 in the horizons, that's something we need to address. And I'm sure this is not the last year of COVID-19. There'll be more things after this. But as it is, we are already done our work so far, and we should actually reach for more vaccination rates in our community, so that these things will not actually hinder our progress in the future. Okay, next. Remember, COVID-19 in children involves families, so you're not just treating the children itself. And I can tell you, after 2.5 years of just doing COVID work and nothing but COVID work in children, we are also treating the father, the mother, the grandmother, the grandfather, and the whole community itself when it comes to one admission of children into our premises. So we do more work actually when a children gets admitted to our premises, and it is important that we look at the children as an individual itself, as a part of a bigger picture that has extensive relations to the other caregivers in the community. So yeah, just bear this in mind when you when you look at children and COVID-19 policies. Next one. All right, so the take-home message is that most pediatric Omicron cases are still mild, and we do home quarantine them, but beware of the red flags so that you can refer early. And remember, COVID-19 in 2022 is different from 2021. We have a lot of atypical symptoms. I've told you about CNS issues, upper airway issues, and gastrointestinal issues, apart from the pulmonary issues. We need to ramp up our PIC kits, and we've seen some MICs coming in, and I'm sure this month is not going to be any different. And I thank you for your attention and also your cooperation. Thank you.
Thank you very much, Dr. C, for this detailed presentation on how the COVID is presented and managed in Malaysia. And I hope this will be very, very useful to our audience because we have now seen comorbidity, atypical GI symptoms and neurological symptoms in this new way. We have vaccines approved of 5 years and above. I have two questions, Dr. C. One, what do you think are the reasons that the uptake in 5 to 11 is pretty low compared to what we see in adolescent? And second, we know that the new data from Sinovac is coming for a population for 3 to 5 and then also up to 6 months. Do you think it's important to have a vaccine which is approved up to 6 months of age in order to give you enough vaccine and enough coverage in this population?
Okay, we answer the first question first, Dr. Ajit. I think when we started the vaccinations for the adolescents, we knew, I think the public knew, everyone knew that we were going downwards from the senior citizens to the 18 years old and below, you know. And true enough, because the adolescents were very highly mobile group, and they had, you know, their own decision making. You know, most adolescents can actually make their own decisions. So most of them would actually follow their peer pressure and actually get vaccinated. So we were very confident that the adolescent population would have no issues when we drafted the guidelines last year. True enough, 92% of them are actually now fully vaccinated. I'm sure the rest is just the vaccine hesitant group, which exists in most populations anyway. But the thing about the under 12s or the 5 to 11s is that a lot of decisions are parental. A lot of decisions are parental, you see. The children has not much say in it. We, of course, as pediatricians are advocates of children under 12 because they can't speak for themselves. And the parents has what we call a wait and see approach. From the start itself, from February itself until now. Despite the fact, I think you will have noticed that we've been very active on webinars, on TVs, on newspapers and everything. We've been very active to promote the vaccines for this group of children. And we even, I think, lobbied very much for the inactivated vaccine, the Sinovac vaccine, which came into on the 7th of March, after NPRA gave a conditional approval for it on the 3rd of March. So the parents now have, the ball is on their court, like, you know, Dr. Ajit, the ball is in your court now. We have given you all the options that you wanted. We have given you all the data that you were worried about, you know, the myocarditis, pericarditis. We refuted all the claims. We gave everyone. But I feel that, you know, most of the decision is up to the parents to make it. And as you can see, we did not make it mandatory. And the thing about the 5 to 11 years old, we did not make it mandatory. So a lot of decisions are up to the parents. And even with the Omicron surge and everything, it was still very difficult to persuade the parents to actually move ahead with the vaccines, especially the ones from the East Coast. As you can see, the numbers are very dismal, Dr. Ajit. So I think we need to plan more, what do you call it, personal approach to many communities, and not just through what do you call it, a top-down kind of approach here. A personal approach by their family doctors. That's why we're having all these webinars. You know, your GPs, which sees you, your pediatricians that administers the vaccines, you know, to your children. You know, those are the ones that you know are the ones who can do a lot of groundwork in reaching out as agents of change, I call them, to these parents, so that they can actually change their mindset and ramp up the numbers of vaccinations among these 5 to 11 years old. Of course, the government on the other side has put a limit up to next month, 15th of May, whereby after that, your first dose of your vaccines will no longer be free. And I think that is also a way of actually, telling people that, if you don't get your vaccines by then, you have to pay for it. And I think from clinicians like us, we have already put up our case for the public court to consider, in terms of admissions to hospital, MISCs, even the deaths, 38 of them during the Omicron. If it doesn't frighten any parents, I don't know what I can do, but I feel that we should go ahead with probably some road shows, because after this, we are going to focus more on the inactivated vaccines, So I agree with you that you're going to have some plans, I think, in the next few months to approach probably the other parts of Malaysia, so that the numbers can actually increase. Yeah, so that's for the first question. And as for the second question, as the previous speaker, Dr. Gao, has nicely put it up, that there is good evidence to suggest that, vaccinations work, even the 2-dose series works. What more, a booster dose in children, below the age of 12. And it's good that, they has some data in the under 5s. I think Pfizer also had some data in the under 5s, but they were not very convincing, and that's why it was not given any approval yet by FDA and CDC. So the more data that we have, as we go down the age groups, I'm sure in the end it will be something like influenza vaccine, whereby now it's given from 6 months and above. That is probably the aim as we go along this vaccine production. I mean, we're only in the second year of this vaccine production anyway. Most traditional vaccines take longer than that to actually reach the target audience anyway. So we actually already on a very fast trajectory already. And as we get more data in, from Sinovac or the other vaccine producers, I'm sure we are heading towards that in the near future.
Thanks, Dr. C. I think you have rightly answered the questions. The need of the hour is to vaccinate as much as we can. We promote vaccination for whatever vaccine, and if safety is a concern, we have to address that. If a vaccine availability, I think out-of-pocket payment may not be a bigger concern. For at least this population, we have seen some barriers to vaccinate in the past, where especially for pediatric population, out-of-pocket payment is not a bigger barrier. But the other barriers are more like hindrance to vaccinate. Anyway, I think it's time to conclude our live webinar today, and I would like to thank all the participants who have been so patient throughout. We have I think exceeded our time limit by almost 35 minutes, and I would like to also thank our esteemed speakers, Dr. Alejandro all the way from Mexico, Dr. Gao from Sinovac China, and Dr. C, who has given us the insight on the COVID management. See, take-home message is COVID pandemic is far from over, and we still need to vaccinate the populations which is still pending, and try to give boosters to the population as seen from the data coming from Chile and Hong Kong. Thank you again, and now we will be projecting our QR code for one CBD point for all the attendees who have attended this webinar. And thank you again, and have a nice weekend.